Hello everyone. So this is a case of Phaco in Intumescent cataract. So doing Phaco in Intumescent cataract, the most important thing is that one should have a very good rexis, because if we have extension of rexis, then yeah, it's possible to do Phaco on those conditions also, but it becomes a little challenging for the beginners like me, because I'm much comfortable with stop and chop as compared to direct chop. So yeah, after staining the intercapsule with refined blue, I saw the main side port wound was little smaller, so I extended it a bit, and then I uh, clean the refined blue and then form the antechamber with visco. Now, since it is an intermission cataract, it's a little hard cataract, so I cannot do the case in topical anesthesia. Uh, I have given the patient a peripheral block before proceeding the case. So once antechamber is formed with visco, now I decided to go for the rexis. So I was well aware that as soon as I took the first prick, the fluid came out. So I aspirated it with the rexis needle. Then I was expecting more fluid to come out. So when I was again inserted my needle, then more fluid was coming out. Then I aspirated it more, and then I decided to start the axis by raising a flap. Now, in this case, when I raised the flap more, some more fluid was coming out, and then I again did few aspiration, and during this maneuver some visco was also lost. So again I filled the antechamber with visco. Now, one thing I should have done, I should have made the triplanar entry, then I inserted a visco, then I could have inserted a visco from there, because now it becomes a little difficult to insert a visco again. But still I go on with it. Now, what other surgeons can do, that we can also go for making a small rexis, then do irrigation aspiration, and then we cut with the Warner Caesar, and with the rexis forcer we can extend the rexis. But I was not having those things, so I decided to go with this technique, because uh, yeah, this if in this stage, when I raise one flap, then if I've done irrigation aspiration by removing the cortex, then there is a chances the flap can extend out, and uh, it may cause extension of the axis and could have led to more problem. But I decided to go to do the axis under cystitome. So very slowly I was doing that. Now I saw that no fluid is coming out. So slowly I was raising the flap, and it was uh, it was circular throughout the axis, and I was experiencing no problem. So when I was completing the when I was about to complete the axis, now in this part, what happens is that the rexes become little difficult to complete, because what happens is several overlapping of the intercapsule occurs, and the strength of the flap becomes little loose, little weak. So what I did, I inserted a visco and flattened the flap, by which what happens that some amount of the flatten can cause some amount of strength of the intercapsular flap, and very slowly I was making the axis, and so on and so forth. On again The flap was coming out, so I was again repositing the flap to opposite side, and somehow somewhat axis was done. Now, after making a triplanar entry, in this case the hydro is not mandatory, because already cortex has been removed by aspiration. And what really happens that if we insert the phaco probe, the water which comes out from the side of the sleeves, it does the hydro by itself. So by making a 2.2 entry with keratom, I inserted a Phaco probe. So when I inserted a Phaco probe, uh, when I inserted, I saw that the rubber tip was little tight on the wound, but the Phaco probe was moving very freely, and I was again moving it front and back, and I noticed that the rubber tip was very, it was rubber tip was very tight in the wound. So what I did, I extended the wound by a little bit, and then I inserted Phaco. Now it was moving freely. So after aspirating few of the matters, nuclear matter, now I just started to go for trenching. Now trenching in mature cataract like this type of case, the trenching should be short and broad, because why it is broad, so that we can easily move the probe from one side to other side. When it is broad, when it is broadened, then we can increase the length of the trench. And one mistake what I was doing is that I was inserting the probe directly in the capsule. One should not insert the probe, it should be partially inserted, because if we insert it, then the nuclear matter comes out and becomes difficult in the visualization. So yeah, but still I was doing it, and the trench was happened. Now I decided to crack the nucleus. So the cracking was done partially, but what mistake I was done again, I was doing applying pressure from both probe side and uh, the dialer side. The In this time in divide and conquer, in stop and chop, the pressure of the crack should be made from the dialer, not from the probe, because in this type of case the mature cataract journals are weak, so there is chance of general dehiscence, but luckily nothing happened. Now it's come for the cracking or chopping. Now in this time chopping, as you notice, my probe is little, uh, it is little slanted, it is little bent towards the other side. Now in trenching, in the probe the bevel end was facing up, but in chopping the bevel end, it was little slightly, it was tilted. So why I tilt this probe? Because in this type of cases the holding becomes very easy, and there is no chance of the nucleus get it get dislodged, the fragment get dislodged, and it was becoming easy for me. And now and also from, I was from dialer, I was holding the nucleus from the back side, and um, I was doing the trenching. Now one half of the nucleus was emulsified, for other half I wanted to rotate it, but was not getting rotated. So I didn't took any stunt in this case. I again refilled the endothelium and AC with visco, and I used the dialer to rotate this other half of the nucleus. Now in this case, uh, I was constantly getting help from the engineers uh, who were involved in this Phaco machine. So I'm not gonna disclose their name, because I'm not having any financial interest on it. So yeah, once I rotated it successfully, then again I inserted the probe and formed the AC with visco. And then again you see my probe is it's tilted for better holding. And again, yeah, I buried it. Now with the dialer I chopped it, I was holding it from the backside with the dialer, and I was able to get emulsify the last the fragments. Now on moving to emulsify this last fragment, I came to epinuclear mode, where my power was very less and my vacuum was also less. And now since in this last part, again what mistake I have done, I should have filled the antechamber with visco, because this is part is called chattering, where the pieces may get dislodged at the PC and it may hurt the PC. but luckily nothing happened like this. Then again, for this part I was facing little problem of emulsifying, so I decided to fill the AC with visco and then do the emulsification. So as you can see that the entry wound side got little the stromal hydration occurred. The reason is that my Phaco probe was little outside, so the water was coming from the side was doing all the stromal hydration. So this is also one should not do in this type of case in Phaco. In Phaco the probe should be straight in the middle, and all the maneuver should be done from the left hand of the dialer. So yeah, the finally the Phaco is all happened. Now some cortical matter left. So what I did, by binomial irrigation, I irrigated the cortical matter, did some hydro with the help of binomial irrigation cannula. Now with the aspiration cannula, I aspirated that cortex by sweeping method, because to get less stretch in the zonules. And finally the aspiration was done successfully. Now uh, by decreasing the vacuum and aspiration flow, i I was doing the last of the part of the irrigation. Now, now few months back I told you about the stromal uh, hydration. So that becomes a little problem for me to remove cortex from the subincisional part. But yeah, slowly. But what I did, I tilted it little upside to see the cortex, but there was no cortex was there. So now it's time to uh, do final visco wash, final polishing, and it was not much left to do since the mature cataract, but still I did some polishing. And as you can see, I was tilting the eye little superiorly to see the cortex, and then luckily there was not much cortex left. And now final polishing, as what I said, the final polishing was done to remove to clean the posterior capsule as much as possible. Now it's time to give the lens. So forming the anterior chamber with viscoelastic substance, I decided to go for implanting the uh, preloaded uh, hydrophilic lens. So it was a very nice lens. So I saw the wound was little small to load it. Then I again increased it a little bit, since a preloaded it was not hydrophilic, it's a hydrophobic lens to be more specific. So I increased the wound, and with the help of wound assisted technique, I inserted the IOL. Now I noticed that trailing haptic was not in the bag. So with the help of dialer on one side and repositor on the other side, I was pushing the IOL in the bag. With the keeping one thing notice, PCs, the zonules are very weak in this type of cases. We cannot expect also the condition of the PC also. So I was not taking any risks. I took visco cannula then, and with the help of visco cannula, I push the haptic, and luckily, yeah, it came in the bag, and now it's came for final uh, visco wash. So everything was looking stable. The lens was in the bag. Rexis was overlapping the optic of the IOL, and it looks quite nice and clean. So now I decided to do the final visco wash, and yeah, everything was looking clean. But suddenly I expected the stromal hydration was also reduced. So the the case was bit okay for me. And since it's a mature cataract, so day one post-op patient will be little happier with this with his outcome. Now it's time to form the anterior chamber by hydrating the side port. So I was hydrating the side port, keeping in mind the AC will be formed, and no iris excess hydration may cause sometimes iris prolapse. So everything I was keeping in mind, and yeah, it was all nice, and it was all okay. And then again I've done hydration of the main wound by hydrating the side pockets, then hydrating the main wound, and it was all fine. Then I checked the wound by tapping, checked the pressure by tapping the cornea. So as soon as when I removed the speculum, I noticed there was some fold in the cornea. I noticed the AC was not quite again it was little decreased. So what I did nothing. I just formed the AC with side port, and the AC was formed. Now everything is great. Now case is closed, and patient was doing fine. Goodbye.